Well, good evening, everybody across the country, and welcome to the Zeiss-sponsored Ophthalmic Clinical Education Summit that is going to cover an interesting topic. This is our second surgical session, and our topic today is going to be biometry and corneal topography and how to achieve better results for your patients. I'm John Hovannessian, and joining me today on our faculty are two real experts, not only for their knowledge of biometry and preoperative measurements, but for their cataract surgical technique expertise as well. Both Daniel Chang from Empire Ion Laser Center in Bakersfield, California, and Sumitra Khandelwal from the Baylor College of Medicine and the Cullen Eye Institute, where she's an associate professor, are experts who you probably know and who I always learn something from. So this is going to be kind of interesting and an interactive session where we're going to, tell real world stories of real patients and what we do. We're not here to talk about products, or this is not a promotional talk. So we can, kind of present what we think is most relevant to you. And similarly, there's really no, holds barred in terms of questions. Here on our Zoom platform, there is a Q&A tab at the bottom that you can click. And if you have questions for us, you can enter them in, we'll see them, and we'll try to answer as many of those as we can in the hour that we have. On the screen is the agenda for today. We're going to start with Daniel presenting some tips on how to capture ideal scans for biometry, and we'll do some cases, a case right after that. Then we'll move into topography. Sumitra will share tips that she's learned, and then we'll talk we'll include as many cases as we can given the time that we have, as well as answer your questions before this short hour is up. So, I'd like to next introduce Daniel Chang, who's going to share with us why preoperative measurements matter and how to get the best scans for our patients. Daniel?
Thanks, John. Looking forward to sharing here. And just want to confirm, you can see my slides here?
Yes.
Great, fantastic. Well, looking forward to sharing about biometry and also talking about topography. And I think the fun part of all these seminars is the case discussion, your opportunity to ask questions, interact. So go ahead and ask questions throughout the presentation. I won't be looking at them, but John and Sumitra will, and we'll compile those at the end of each talk when we have some discussion time. We have plenty of time built in. So hopefully this will be a learning experience for you. And hopefully enjoyable as well. So I'm going to talk about capturing the perfect scans, why preoperative measurements matter. Perfect is a high bar to set, but that's what we should try to shoot for, I suppose. Again, these are my financial interests, obviously with Carl Zeiss. And preoperative measurements matter for two reasons, or we need two things. Number one is we need good measurements. And number two is we need information on the quality of the measurements. And they're slightly different concepts, but they're actually interrelated and they're both important. We want accurate measurements because we want to improve our outcomes. We need the actual numbers to put into formulas to know what lenses or astigmatism we correct. But it also would be nice to know how good those numbers are. We could potentially have some keratometry numbers have 3 diopters of astigmatism, but we don't know if that's regular or irregular. So we need some way to get information on how good those measurements are. And that basically minimizes our surprises. There's always a discussion is, hey, if I want to correct astigmatism, do I need corneal topography? Hopefully after this session, if you think no, that you'll know, yes, we definitely need it. Well, technically you can correct astigmatism without topography, but you're going to get an awful lot of surprises and some pretty unhappy patients. So we try to minimize surprises, and with each technology or technique we add, we're trying to get better outcomes and minimize surprises. So first, for accurate measurements, that's the basic biometry. You want to get numbers, your axial length, ACD, lens thickness, white to white, keratometry, those kind of things, because that data goes into a formula, which gives you the power both for the absolute sphere power and also the astigmatism. And the most important thing since the advent of optical biometry is the keratometry component. Back in the ultrasound days when we did that routinely, we had to worry about getting good scans, and axial length affects your power of the eyeball quite a bit. But with the partial coherence interferometry with the IOLMaster 500, now the swept source OCT of the IOLMaster 700, and even some of the other devices using optical biometry, that axial length measurement is actually pretty robust. Checking the fixation is certainly important, but getting the keratometry measurements, particularly in this dry eye population, is going to be critical. So let's talk a little bit about how we get keratometry and how that could potentially can be affected by technology. Because we hear from time to time about, oh, keratometry and this zone, that zone, it gets confusing to me. So until I really looked into it to try to understand what exactly we're measuring, it was difficult to kind of make sense of it. So the idea is that we put a reflection on the cornea, specific Purkinje patterns here, where the distance between the Purkinje is going to indirectly determine the curvature, not the keratometry, but the curvature of the cornea, so the shape of the cornea. And the further apart the spots are, the flatter the cornea is, the closer together, the steeper it is. And since we know how far it is on the biometer, and if we know how far the biometer is from the cornea, we can calculate what that radius of curvature is going to be. From that, we derive the the Ks and the axis. And we use this kind of virtual index of refraction. So every time you look at a biometry or a keratometry measurement, you'll see this N value. And the cornea is really 1.376, but the number we use in keratometry is 1.3375. So that's not really the refractive index of the cornea, but it's kind of a fudge factor that takes into account both the anterior and the posterior cornea. We'll talk about posterior cornea a little bit later, but the idea is that by approximating that, we can figure out what the keratometry value is, put it into our formula, and get some calculations. So one of the things that's important is, how do we measure these spots, these keratometry spots? And there's a concept called telocentric keratometry. So typically, if we reflect light off the cornea, the distance between the machine and the cornea affects how that spacing is going to be. But with telocentric keratometry, there's kind of a mini optical bench behind each one of these spots. If you look on the front end of an IOL Master 700, you see little glass, not little dots of light, but little glass, because there's lenses and optics behind each one. And this basically creates a device distance independent spacing of reflections. So no matter how close or how far you're from the cornea, the spots remain the same. So for a non-telocentric biometer, your spot distance is going to depend on how far or how close you are to the cornea. Whereas with a telocentric biometer like the IOL Master 700, you're not going to have to worry about that quite as much. So here on the left, you have a telocentric keratometer. On the right is non-telocentric. So as you move further, you can see how the spots get a little bit blurrier on the left, but the spacing actually changes. So if you're not just right with your distance, your calculations will be off if you don't have telocentric keratometry. Now, at the end of the day, different keratometers have the ability in viewfinders to get the distance just right, but what happens is it adds to your measurement time. So by being able to get a measurement where you're not quite picky or super picky about the distance, is you speed it up. You get better measurements, but you can also speed up the measurements, which is important. So again, telocentric keratometry provides less dependence on the device alignment, takes away a variable in your keratometry measurement. So the fewer variables, the better, and it can facilitate a faster measurement. Remember, the tear breakup time in a lot of these cataract patients is probably like 5 to 10 seconds. So it's not like you want them staring, because by that time the tear film breaks up, your keratometry numbers are all over the place. So with a good biometer, you can get good accurate measurements, but also, like I said, you want information on the quality. How do I know how good these measurements are? So what you want to do is screen for potential problems. Now, again, I mentioned the swept source OCT. There's different cameras on the IOL Master 700. You get a lot of images, boom, right there with every scan, which is really nice. Additional devices like the Atlas topographer. Dr. Kandawal is going to talk about topography and how that relates. An OCT, which gives you a higher resolution view of the macula, can certainly be helpful as well. So let's look at the information we get from the IOL Master 700. And there's a saying that says a picture is worth 1,000 words. Well, you get 4 pictures right here. So that's like 4,000 words right there. So when you look, the top here is a whole eye swept source OCT. So you see cornea all the way to fovea, which is fantastic. You see in this particular case, some cortical smoking in the cataract. You can see some nuclear sclerosis. You can see that the lens is in a normal position and tilt. And you can see there's a clear view to the fovea. And also the fact that you see the fovea means that you're fixating well. Over here is a keratometry spot pattern. You can see where the pupil is relative to the keratometry pattern. All the dots are nice and crisp. They're not smeared. They're good. And you have an eye image, which shows the offset of the visual axis, or the light reflects there in the center of the pupil, which is labeled on the printout as a CW or Chang wearing cord. We also call it cord mu, or most commonly referred to as angle kappa, which is a little bit of a misnomer, but it's a cord separation. And then, of course, the view of the fovea. So when you have a normal view of the fovea, you know that the patient is actually looking and there's good fixation going on there. So let's look at this scan here, which you notice is there's some movement artifact. There's all these different tracings of the RPE. Since there's 6 tracings that actually makes this OCT scan, you're looking at an aggregation of all 6 of them. You know there's some movement going on, and you just have to be cautious about the numbers that you get there. So that's a quick and easy way, just visually, to look for the quality of the scan. Here's another scan. You see, hey, there's no fixation. There's no foveal pit. You had hit some peripheral retina somewhere. So this scan, probably a little bit off. You want to be careful of that as well. So you want to look for the clean foveal pit as it goes down through here. It has a little matching area down here. So you know you're in the fovea. So on this scan here, you notice there's some nuclear sclerosis as well. You notice on this scan, though, you have to be careful of interpreting this because the overall signal strength reaching the fovea is down, so there's lightness. But this particular scan is actually normalized. So you can't look at the absolute intensity of the darkness of the lens to determine how advanced the cataract is. But you can actually see the internal layers, which is kind of cool. So you can tell if there's a lot of opalescence versus cortical versus PSC, but just be careful in terms of trying to grade a cataract. It just gives you more of a subjective than an objective numerical value there. So again, there can be signal attenuation. So if you're having trouble seeing the foveal image, it means most of that signal has been taken out by the cataract. So if you look here, you see a posterior subcapsular cataract. You can see this sometimes on a PCO on an IOL, or sometimes even if there's a lot of glistenings on the surface of an IOL, you can pick that up as well. And you can notice there's very low signal strength because the posterior subcapsular cataract scatters the measuring OCT light. Now, the good thing about the subsource OCT, it's a higher wavelength, so it penetrates much better cataracts than other optical biometries like a partial coherence technology. Also, it scans a bigger range, so you have a much higher chance of getting through even some, what you would think, pretty dark or even white cataracts. It can sometimes measure through that, which is really nice. Here's an example of an IOL. You can see the spacing between the lens and the back of the iris. You can see this one probably has a little bit of a PCO going on there. But you can sometimes guesstimate or see what type is, or certainly you can see if an IOL is in the sulcus or in the wrong position just by looking at the whole IOCT there. Again, nice clear view of the fovea. You do want to make sure that the very straight line of the measurement is always going to have some reflection artifacts, so don't make too much of that right on the axis of the device. You can also see Purkinje images here in the white-to-white image, so you know you have a IOL there, and don't try to do calcs on that one unless you're planning to do an exchange. And in this scan, you can look at the fovea. There's a little bit of a cataract there, maybe some dry eye, some smears on these spots you can easily pick up just by looking at the picture. And of course, the fovea is thick. This particular patient had some diabetic macular edema. One thing that's nice is on the scan, if you look, there's a indication of an exclamation point, which is some borderline values. And this particular scan with those keratometry spots did say that, hey, these numbers, even though the standard deviation of the measurement is pretty consistent, they may not be high quality. And we'll actually have a case, hopefully if we get to it, that highlights that. Here's another scan of an eye, some cataracts, has some macular pucker. So if you get a serous OCT here, you can say, hey, there's definitely an epiretinal membrane on top, some distortion of the foveal architecture, and it's something we have to be careful about, visual acuity and visual potential, particularly if we want to do a presbyopia correcting lens. Here's another scan. This one happens to actually be of my mom with a lamellar hole in the left eye. Maybe had a little bit of dry eye as well. And if you look at the OCT, you can obviously see the lamellar hole. She actually had this for many years. It's been consistent and stable. And I did her cataract a few years back. And she's done very well. So again, why preoperative measurements matter is you want great measurements. You want information on quality, take all this together. And you want to do it quickly because the eye changes as you're measuring because you have a poor tear breakup time in a cataract age population. So at the end of the day, with good measurements, information on quality, you end up with some happy patients. And as I alluded to, that leads to a happy surgeon. I did my mom's surgery back in 2017. She got a EDOF or symphony lenses in both of her eyes. I did my mother-in-law last year as well, and she did the same, and they've both done well. So I still have happy moms and mother-in-laws who love me. And I certainly enjoy doing good measurements, getting great results to patients. And I think you can as well by applying these principles. Thank you very much.
Terrific. Well done, Daniel. And yeah, my next question was, do you love your mother-in-law as well? She loves you with your result, but it sounds like you do very much. Nice, healthy relationship with the mother-in-law.
I actually did my brother's former mother-in-law as well. So got a lot of family members. My dad's cataract's not quite ready. We'll see what he gets, but certainly I'll be measuring using these techniques, using telecentric biometry, using multiple measurements we'll talk through some of that kind of the methods of doing that.
Yeah, you gave some great pearls there. Just a quick thing. I have noticed it's been a couple years since my practice made the change to the 700 from the previous biometer, the 500. And I can't remember the last time we've had a case where we couldn't get a scan. Previously with the 500, we had, more dense cataracts, especially dense cortical cataracts. It was sometimes difficult to get a scan at all. I had to do immersion. Tell us about your experience on that as well.
Yeah, for sure. Even if you do like 90%, when you have 10% that you can't scan through, it's a real hassle in your clinic. And the challenge is the more times you have to break, the less you're doing immersion A scan, the less good your staff is at doing it. Yep. And then you can't find the biometer. So now the iMaster 700 gets through just about everything, 4+ cataracts, PSC cataracts, even some kind of mildly white cataracts. And really truly the ones that can't get through, I mean, it's not like a little bit of a PSC that you just can't get through. These are really hand motion type cataracts. So those are patients where, okay, you maybe spend the extra time, your immersion A scan skills aren't what they used to be. You get the numbers and you can do it and the patient will do well, but it certainly helps with the patient flow and just not having another one we have to kind of measure. We do have a nonprofit as well, so I do see some pretty advanced cataracts and it's nice to be able to do that.
Great, and I understand you have a case presentation for us as well. We'd love to.
Yeah, absolutely. So let me see if I can pull it up.
Sumitra, any tips you have or suggestions regarding, what makes a good scan for you and, where you pay particularly close attention to your biometry?
Well, for us, Daniel pointed out that a picture's worth 1,000 words. We've really trained our technicians to look at that first, picture that has the images of the reflective dots to catch any ocular surface issues, plus topography, of course, to see if there's anything strange about the retina scan, the foveal centration too. And I think what we've just really found is that we can do more and more biometry on these patients, and because we see a lot of patients with ocular surface disease, but also a lot of patients who have really long eyes, actually. The biometry is always going to be better than the immersion for those eyes.
You bet. It looks like you have your slides here, Daniel.
Yep. So the first case is I'm going to make this actually nice and simple. I'm going to tell you what it is to get off. It's actually a 40-year-old patient who wanted to decrease dependence on glasses. Came in for a refractive consult. Had a refraction of +3, -1, and 175 at 6. Was 20/20 with not much glare. So this is not a California cataract. This is actually a lensectomy patient or a lens extraction patient. And we can talk about at what ages you want to do lens extraction versus LASIK. But I looked through a number of cases, and if you want one that's really clean and just distills the issue, it's easiest on these younger patients because they're generally healthy. But this is the biometry scan. It was an iMaster 700 of the right eye. And here's your topography. So basically pretty clean with the rule of astigmatism. So one of the questions I have is what's your general approach? I mean, I think this is kind of, leads to discussions. You have a patient who wants correction of astigmatism, presbyopia, et cetera. Do you have a particular algorithm or how you do this? As they come in, what measurements do you get? Obviously there's a clinical exam, but from a diagnostic standpoint, what do you get? How do you get it?
Sumitra, do you want to take first crack at that, and I'll follow?
Absolutely. I've really changed the way that I have done my clinic flow. I used to have the patients come in and I would first do a topography on them and then just take a look at them and then chat with them and discuss with them all the different options. But I really found that doesn't give you all the information. I'd go down a rabbit hole about a multifocal lens, for example, and I wouldn't get the OCT macula until their pre-op visit. And then they're already all pumped up, ready for that multifocal. And then I'll catch something on that exam. And of course, back then we didn't have the 700. And so I wasn't even able to catch these little areas in the foveal centration. So I've really started just kind of doing it all. I find that with the speed of the 700, the fact that the OCT is just down the hall for us, getting all three measurements, the biometry, the topographer, and the OCT macula before I even step foot in the room is really helpful for my clinic flow. Now I have trained my technicians to look at the topography, and if it looks really strange, to just stop the whole process right there and come and grab me. But that's how I've changed my clinic flow.
Yeah, I guess the thing I'd add, that the great comments, Sumitra, I completely agree. It's really helpful to have one conversation with the patient and to have as much information before that as you can. And dry eye is, of course, the enemy of accuracy, and topography is a terrific way to screen for it. I think there are a number of other useful tools like the HD Analyzer. I really like the assessment of the point spread function over time that instrument provides. But you can look at a topography and get a sense how dry the eye is. And it's really refreshing, isn't it, Daniel? Here you got a young patient with a pretty nice looking topography. Everything looks pretty clean with these measurements. So I'm guessing you didn't have a whole lot of dry eye to clean up in this case. Is that right?
Yeah, this was good. And I won't delve too much into topography. This is just normal. But I'll let Sumitra take the topography discussion. So, and I do like the Biometry 700 because it gives that information. You get a little snippet of the fovea. So if somebody has macular edema or some other issues, boom, you know that off the spot. You know how much astigmatism they have. You can look at the lens, get an idea of the status of that. You know, you can look at the white to white, the reflections, make sure they're clean. So it's just a quick picture without even looking at numbers, because I don't know about you guys, but when I look at a grid of numbers, my eyes just kind of go across.
Yeah.
I can do it, but it's just, I can't skim it and talk and look at it and say, hey, this looks normal. Yeah. So one of the things about the Biometry 700 that's kind of both good and takes, some, figuring out how to work with is it does give us a lot of measurements and it gives us a lot of pages. So there's kind of a challenge of, what do you look at first? And I've actually have it kind of dialed down. This has both biometric values, which has all the individual measurements. There's corneal values looking at cornea, anterior, posterior, and total K or the TK. And then of course there's a reference image, which I use to help me with astigmatism. What I like to do is basically focus on this particular scan, which is the analyze for each eye. And specifically, I just look at the pictures, just like I said earlier. It's those pages, sometimes I print, sometimes I don't print. I kind of glance at them, but what I really look at is this eye image. Look through the things, look at the lens, the reflections, the eye fixation. It takes me just a few seconds to do that. As I'm talking to the patient, I just kind of thumb through it, just put my initial on it. Right now, we're still printing. We may eventually get that part digital as well, but it's just a kind of a quick scan. And it gives me an overview of what's going on, so it's nice. The other thing that's helpful is with the Biometry 700s, it does do the IOL calculations, which is the next step, and it does have the Barrett formula, which I find is kind of a simple go-to formula. I use the multi-formula calculation here. So if you look at this is for the right eye measurement, is I have SRKT, Barrett Universal 2, Holiday 2, more for legacy purposes, and then the Barrett TK Universal 2. And they actually break it down pretty well, and in terms of how to interpret just regular Ks versus total Ks. The numbers up here, this gives you pretty much everything you need to know from a scan standpoint. I can go back and look at the pictures, then I look at this section right here. I could go through all the other pages and look at all the tables and look at each individual scan. But what we have here is a standard deviation measurement. And the short of it is, the standard deviation is single digit, you're in good shape. If it's double digit, you're probably okay. The only one you really worry about is axial length, and then keratometry. And then the nice thing is you have all the numbers right up here, and this is the regular Ks. And then you get the TKs, which is the combined effect of the front and back cornea. So what the Biometry does is, as a reflective measurement of the anterior, and it uses OCT to calculate the posterior surface. Because using just swept source OCT to try to measure anterior surface just doesn't have the resolution of a reflective technique. So it piggybacks on great anterior K measurements to calculate the posterior. In this case, you actually see the astigmatism is quite similar. So the anterior posterior is or the total is about the same. So the contribution of the posterior is not that much in this particular case. And then these, if you look at the top left corner, it says just regular K. So these are just regular K's calculations for these formulas. And then this one's a TK calculation. So it shows in the top left box a TK. And we have a question, I believe, is asking, is sometimes it's needed to put a refraction. The IOL calcs, is it better using old refraction or new refraction? I think specifically that's referring to the Holiday 2. And actually what I like to do is I actually compare multiple scans. I'll touch on that in a minute. So that's why I like using the Barrett, as you don't need the refraction data. It shows good accuracy without having to worry about, what refraction is, the pre-cataract or especially with post-LASIK pre-cataract, it gets really complicated. But these are just measurement-only formulas. And of course, they show the difference in astigmatism here is pretty minimal. So it's a nice single page that gives you, when you kind of break it down, you look at the pictures on the calc pages, I mean the measurement analyze page, you look at the calc page, and as I alluded to, I like to do 2 measurements. So here's July 5th and here's July 26th, just a few weeks apart, usually 1 or 2 weeks apart, that looks at the same measurements. So I have the same numbers. You look super consistent here, you know, in terms of axis length, 2/100th of a millimeter, keratometry within what 0.06 diopters. The astigmatism is within 1/10 of a diopter, and also for the total Ks. And the net calculated IOL power within, I think if it's within 0.3, it's fine. In this case, it's within about what, 1/10 of a diopter, both for the regular K and the TK. So when I get numbers like that, it makes me really confident that I'm going to be able to, at least using these formulas, figuring out the astigmatism correction, you're not overcorrecting for posterior cornea in this case, be able to get this patient a good result.
What's your threshold for doing maybe a 3rd scan or something else to improve your accuracy?
Good question. This is kind of like my poor man's way of testing the ocular surface, because, you know, if you have variability in Ks and that's significant pre-op, you expect to have a post-op. And what I like to look at is my final IOL power calc, right? So if my power calc is greater than 0.3, 0.4 diopters, which is about translates to about 1/4 diopter on the 4-opter. So if I'm like, you know, 2/3 of a diopter different in my anticipated calculated value, then I know my refraction is going to be greater than, you know, 1/3 or 1/2 a diopter. So that makes me worried, and I would do a 3rd set. Similar with astigmatism, if it's more than like, you know, at 0.3, 0.4, the axis is greater than 10. I also look at my topography for the axis. I prefer to calculate or treat off the IOL master axis, but I like to look at that just to make sure it's regular and give me kind of some guidance there. So there's no magical number, but again, this is kind of a quick way. If you're thinking, how much fluctuation do you want post-op? If you don't care if the patient fluctuates a diopter post-op, great, they can fluctuate a diopter pre-op. But most people want that, you know, ideally within less than 1/2 a diopter, 0.3, 0.4. And then when it comes time for the 3rd ones, you have that discussion. You say, hey, you know, I've measured you a couple of times, you got some fluctuation, you know, you're having fluctuation now, you're noticing in your vision, oh yeah, it fluctuates. Well, you're gonna have this issue afterwards unless we treat the ocular surface, you know, be ready for it using tears, using whatever we can do to do that.
And of course, to say nothing of the quality of vision that'll be affected by the fluctuation post-op. So yeah, outstanding.
To add something really quickly, I think, Daniel, you brought up a really great point, which is you could really start chasing dry eye ocular surface if you keep following topography. Like some patients will never have 2, 3 stable topographies, and you have to wave the white flag. But if you've got repeated biometry and they call for a very similar lens, I think that's when we start to accept that the patients are, you know, they have a certain type of cornea. Because I definitely see issues with contact lens warpage, for example, like with toric soft lenses, issues with ocular surface issues. And what they end up doing is kind of going down a rabbit hole there too, where it ends up being, when is my topography going to be you know, be similar to the previous ones? And the reality is it's never going to be the same.
Yeah, and I like to use topography as, again, a screening tool. I don't use it for calcs. I don't use SimKs, that kind of stuff. And it's like, what exactly is the impact of variations in topography on outcomes? Well, we know the direct impact for the biometry values, because that goes directly into the formulas, your anticipated dioptric impact. So they're complementary technologies, but again, recognizing the role of each is very helpful, which I think goes into your talk.
One thing, yeah, just before Sumitra launches into her talk, that was outstanding, Daniel. Thank you. Another tool that is very useful is called Zeiss Veracity Surgical. Now, this is a tool that takes information from all of your diagnostic equipment, whether it's Zeiss equipment or not. If you use a LensStar, it'll accept that data. If you use a non-Zeiss topographer, it will take in those data as structured data and allow you then to do your lens planning on one interface that takes all the equipment from different machines. It allows you to look at your images that come from any machine in your office as well, so you can validate the quality of the measurements. And click between different choices so that you can see what the refractive effect or expected refractive effect is of using different generated keratometry values and axial length. So it's a very useful tool that will save you a ton of time in planning surgery. So everyone should be aware of that as well. So Sumitra, let's talk about the other part of the equation, which is corneal topography. Demystify this for us.
Absolutely, absolutely. Well, I think this is also a great segue because, as I said before, there are definitely surgeons out there, more so in the past, that have not always utilized topography, as a screening tool. But I think it becomes even more important, not just for those eyes that are interested in toric lenses, but also for those that are interested even in a monofocal lens. For example, I have this patient who's 65 years old, who's presenting with decreased vision, referred for cataract evaluation. The recommendation is possibly a toric, but he's coming in saying, listen, I understand there's just astigmatism correcting lens. I'm not really interested in paying out of pocket. I don't mind wearing glasses. And his vision definitely has some asymmetry with 2.5 diopters in his glasses in the left eye and only correct the 20/50 compared to 0.5. And so if you just went through and said, okay, this patient's getting a monofocal, I'm going to just move ahead with my biometry and just put a monofocal in, you would have missed a case like this where actually that patient has keratoconus in that left eye. And even though he's not interested in a toric lens, the reality is, even if he gets a monofocal lens, I don't know how much he's going to get better than 20/50. He may only get best corrected 20/30 with glasses because of that asymmetric stigmatism, because of that inferior steepening. And so when you start talking to this patient, he's like, well, yeah, the left eye's been blurry for, the last 20 years. I just kind of thought it was my quote unquote weak eye. But for a patient like this, even if they're having a monofocal, it's important to catch this. If afterwards he didn't have a very good outcome, even with a monofocal, and you showed the topography at that point in time, by then he's like, wait, you never talked about this beforehand. So it becomes important for all patients to get screening topography. And there's a lot of applications for topography. Management of astigmatism, well, we all know different options for toric lenses and relaxing incisions, but also you want to be able to say, okay, I'm going to place a multifocal lens in a patient like this. Am I going to be able to touch them up, for example? In a case like this, you probably wouldn't place a multifocal anyways, but some of these more irregular astigmatism or maybe formed fruste keratoconus, you may not go that route. You want to explain unexpected results, such as this case. And then there's post-refractive surgery corneas that you may be able to utilize topography to help calculate the IOL power. In addition, it's very important in refractive surgery. And I think any refractive surgeon would say that not only is topography screening for them, but it's something that they follow over time to make sure that patients are good candidates going into the procedure and to monitor post-op outcomes as well as plan retreatments. And it's also something that can catch different complications in the past, like central islands or decentered ablations, as I said, plan retreatments. And then for corneal surgery, it becomes useful to explaining unexpected results, ocular surface disease, anterior basement membrane dystrophy, both in cornea procedures as well as cataract surgery, diagnosing ectatic disorders, managing post-op astigmatism after PKP, and just overall whether or not a pathology, like say a pterygium that may not be growing onto the central part of the cornea, may be causing a lot of flattening. That's something you want to address, because even if the patient's 20/20, their quality of vision may not be good due to that flattening effect of that pterygium. So we're going to kind of take it to the basics of placido imaging. Placido imaging is where you have rings reflected off the anterior corneal surface, and there's reconstruction of the corneal curvature based on these different ring spacings. So you have the placido device, and then you have the reflection by the digital camera off the cornea. And where you have areas that the rings are closer together, that indicates that the cornea area in that area is steeper. But areas where the rings are further apart, you have flatter areas of the cornea, and it's all relative. And so this is an example of how those rings then result in an image that we're all very familiar with. But there's more than just that typical map. There's various options for topographic maps on whatever topographer you use. And the nice thing about it too is you can customize it to what you desire in that evaluation. For example, we have a cataract evaluation set up, for example, versus a refractive, because you're looking for two different types of measurements and maps. And so we'll go over a few of the maps that are available. The photokeratoscopic is very important because it gives you the reflected rings and the Myers. And the Myers give you qualitative information as well as quantitative. And it determines the quality of the map, making sure that the actual device was centered on the pupil, for example, making sure that the quality of the cornea is okay, because if you have irregularities to the tear film, that can affect the map quality. And so a lot of the data you're going to get, such as the actual astigmatism values, aren't really worth much if the cornea is irregular. In addition, you can catch things like areas where the data is missing, and you can see whether or not that correlates to any areas of the slit lamp exam. Perhaps it's anterior basement membrane dystrophy or areas of haze, areas of Salzmann nodules. And for us, we've trained our staff to catch these irregularities on the placido image to sort of stop the exam and have us come take a look before they continue on with various other measurements, because this patient may need optimization of the surface or perhaps a different diagnosis before going on to have cataract surgery. So here's an example. You see irregular mires. You see decentered placido rings. The patient just wasn't quite able to center compared to that pupil center. And here's another example. This is a patient who had superior anterior basement membrane dystrophy. And to be really honest, if you don't lift that upper eyelid, you're not going to necessarily catch some of these diseases, such as that superior irregularity. And so here, this missing data, doesn't matter if the patient has 4 diopters of astigmatism. It's really not a good quality scan. It's not a good quality cornea. I need to address these issues prior to any procedure. There are some questions about axial maps versus tangential. And I think a lot of us are drawn to the axial map. It's what we're familiar with. But it's important with topography to understand where these measurements are coming from. So on axial map, the measurements are tied to the optical axis. And all the radii share that same axis of origin. So it's very good for central and paracentral corneal pathology, but not as accurate in the periphery. As you get out there, there's variations in that radii from that optical axis. Compare that to a tangential map. This is not tied to that optical axis. Each curvature is based on the neighboring points. And so it gives you more data in the periphery and is able to detect irregular astigmatism. But the problem with this map, and the reason why most people aren't drawn to it at first, is it gives you a lot of noise, especially in the central cornea. But you need to utilize both maps when you assess for irregular astigmatism. So here's an example of an axial versus a tangential map. And it's important to note that the SIM-Ks are calculated from that axial map. And you can see on the left that it looks pretty normal. There's a little bit of areas of steepening centrally, but compared to the tangential map on the right, you see a lot more noise and you're catching some of that peripheral relative flattening as well. Here's sort of a typical topography for, say, a refractive procedure. In this example, we have the axial map on the left top, the tangential on the top right, elevation map on the bottom left, and then the photokeratoscopic view. You want to make sure the patient's name in the correct eye, of course, the quality of the scan. You want to look at the color diopter steps. It's very important when you're doing different assessments. You can really change how dramatic any changes of topography are by just changing the diopter steps. And it's very hard to compare different topographies if you don't have the same color diopter steps. You want to look at the axial map, which here you see that astigmatism centrally that looks a little bit irregular, a bit of a asymmetric bow tie with some inferior steepening. And the tangential map on the right gives you a little bit more noise centrally, but does confirm that astigmatism centrally, but also some peripheral flattening. And then you can choose what you want to do with that bottom left map for these examples, which shows the elevation map here, but there are a lot of other options available as well. Here's another example of a similar type map. And what you're really catching here is there's some areas that are missing on the axial and tangential maps because this patient has some Salzmann nodules in the area. Also, look how different the axial and the tangential map look. I mean, those don't even look at the same patient. So you can be really fooled by this because somebody changed the color diopter step so that the axial map is in 0.5 color diopter steps, but then the tangential map actually is in 1 diopter steps. And so you end up having a very different look between the two when in fact this is the same patient. So always important to address the diopter steps. Another nice map that showcases is the keratometric map, and that gives you numeric areas and actual numbers in the area. It also gives you the 1, 2, 3, 4, 5 millimeter zones, which can be helpful for some of the different formulas, say the Wang-Koch-Maloney formula for prior myopic laser surgery. You can also catch things such as if they have very irregular astigmatism. Here we have, this is kind of what I like to do for my cataract evaluations. I've got the axial curvature on the top left, and I've got the different rings available there so that I can notice if there's any changes in that 4 millimeter zone. I've got some corneal wavefront on the top right, which I'll go into a few more details. And on the bottom left, I've got the keratometry. So this patient has quite a bit of irregular astigmatism, notable on the axial map and really confirmed by that tangential curvature. And if you look here at that central 3 millimeters on the numeric keratometry, you can really see that there's really no pattern there. This patient has as much from 45 to 47 as far as the differences in diopters, and really it's a lot of irregular astigmatism. Note that that difference in that central 3 millimeters between 45 and 47 is very different than the 0.95 that the SIMK just spits out from you based on the axial curvature alone. So what are some of the other bells and whistles that you can use? Well, you can use things like a map comparison. So in this example, once again, you want to make sure that the maps are similar between the eyes. Here, this is an example of what happens with change. This is someone who had myopic refractive surgery, so you can see that central flattening effect. It's a patient with keratoconus who underwent cross-linking that was followed with time. There's also something called a pathfinder, and this has been really useful as a screening tool on the atlas topography, for example. You have a patient like this that has a very normal topography, and it'll say 93% normal. A patient like this who has quite a bit of astigmatism, but it's very symmetric, actually, compared to this patient that has inferior steepening on the mean curvature, where this is a suspect of keratoconus. There's this patient who has central steepening, for example, and this can give you a suggestion that maybe this patient had hyperopic LASIK. And I actually had a patient who said, oh, no, I've never had any prior procedures, but we were able to see, hey, you have this central flattening, these little central areas of steepness. Oh, actually, yeah, I did have LASIK. I mean, it's amazing how some patients don't necessarily think what exactly laser surgery was for them. To them, if they didn't go to the OR, it wasn't actually surgery. And then this patient, for example, said, oh, I had LASIK, but you're not quite sure what type of LASIK they had. And the Pathfinder gives you myopic laser as a suggestion. Lastly, it's nice to have some of these corneal wavefront, and it's directly on the topographer, and it gives you that image stimulation in the bottom left that can actually help educate the patient as well. So this patient here, we see there that they have, relatively normal cornea, and they have spherical aberrations there, positive spherical aberrations. So in this patient, we end up discussing whether or not they'd be a candidate for a premium lens, and what type of lens. Most of the lenses we have available are pretty good for a patient that has some positive sphericity in their cornea. But compare that to this patient that had quite a bit of steepness centrally. This patient did have a history of hyperopic LASIK, and I mean 49 diopters steep K. That's a very unstable, peak to their cornea. And when you look down here, it says the spherical aberrations is quite negative, very high, a lot of higher order aberrations, but also very negative. And so this patient, you're really going to want to put something like a positive spherical lens, maybe even a spheric lens. And you can really showcase with that image stimulation down to the bottom left, hey, yes, you have a cataract, but I'm going to be doing cataract surgery, but this is the way your cornea sees, and you've got irregularities to that surface because of your prior LASIK. We may never get the quality of vision that you're looking for, but we're going to do our best to get you seeing as good as possible, and afterwards we'll address some of these corneal issues. So in summary, this is an essential part of the anterior segment workup, and there's a lot of different bells and whistles on your platform. It's really important to kind of understand that and constantly kind of decide how the different maps availability fits into your practice.
Outstanding. Boy, Sumitra, that was really a terrific step-by-step approach to how you can use topography to improve your understanding of the patient. I want to make it a little bit practical and ask both you and Daniel, are there specific criteria you use, maybe numeric criteria that you use? I'm looking at a patient and their topography looks a little bit funny, but is this patient a candidate for a multifocal or not? What are the steps that you would take to answer that?
Yeah, honestly, I don't have any magical numbers. I look at the map. I like the axial map. I'll take a look at those tangential maps. I like actually the elevation map as well. That takes a spherical approximation of the cornea and prints everything out, or just calculates everything on top of that sphere. Gives a good pattern display as well. But I like to look at graphically what it looks like. And one of the things about the atlas is it doesn't do the kind of signal averaging. I think a lot of topographers will throw out the high ordered aberrations because they want you just to look at the basic, maybe up to 3 orders of aberrations. So you see overall shapes and you never see the irregularities. So you can't pick up that stuff. So if the astigmatism looks fairly regular on the topography. There's no, weird dry stuff. I don't specifically look at HOAs and cutoff. Similarly with the angle kappa is the common term. The term that George Waring and I coined was the chord mu, or the Iowa Master calls it the CW, or the Chang-Waring chord, is the offset of the visual axis with the center of the pupil. People have thrown out numbers of 0.3, 0.4. I think ultimately you have to remember is two things. Number one is if you have aberrations on the cornea before your cataract surgery, you're most likely, unless you did something funny, have the same aberrations on that cornea after cataract surgery. And for a patient, they're not perceiving, you didn't cause those aberrations. They perceive the difference between a cataract and an IOL. So if they have these aberrations for years and they still have them, well, it doesn't improve them, but it doesn't necessarily make them worse. And let's say a multifocal IOL, there's certain quality of image decline with the EDOF, like the Symphony, where it's very good image quality. They tend to continue to tolerate that corneas. So if your cornea has overall a lot of aberrations, you put a lens that's going to compromise, maybe one with a lot of chromatic aberration, or one with just that's a multifocal or trifocal, then you're going to run into issues because their net image quality is going to be declined quite a bit. So again, it's a relative consideration. Also for centration, there's actually no real clinical data that shows, unless you have something that's just grossly correctopic, where angle kappa, chord mu, Chang-Waring chord, whatever you want to call it, directly affects the outcome. It's mainly where that lens ends up sitting and where you put it that matters. And at the end of the day, if you decenter, you're going to induce astigmatism, which can be fixable. You'd like not to. So again, none of these things are really hugely critical where there's a strict cutoff, particularly if you use a lens that has good image quality, good MTF, where you have some kind of give in terms of your image quality for the patient.
Yeah, Daniel, that CW cord, what another wonderful feather in his cap for David Chang, who worked with George Waring on that. No, I'm kidding, of course.
Thanks,
that was Daniel Chang who we owe that our thanks to on that.
Most of the other stuff is David. That's my
for me, I'd agree with you. The CW chord of 0.3, 0.4, and then the other number that I like to look at is higher order aberrations, the corneal higher order aberrations in the central cornea. When those are 0.5 or above, that's kind of a good warning sign. And there are a number of studies that show an inverse correlation between multifocal satisfaction and a high order aberration.
Generally, and what I like to ask, particularly post LASIK patients, you're generally not going to have high order aberrations unless you have obvious ocular surface issue, except in the post LASIK patients. And the one question I ask these patients is, were you ever happy with your LASIK? And if they said, yeah, I loved that, great vision for years, then you think, okay, the LASIK was pretty good. If they're like, you know what, my vision was never quite right after LASIK, watch out, because it's not going to be good after the cataract surgery. So there's kind of a historical question. And then you obviously look at all the data as well.
Yeah, good. So Mitra, I love your answer. And then if you want to launch right into your case after that, feel free.
Well, I think Daniel has a really good point too about, some of these, newer multifocals. I think there's still just a large number of surgeons out there who are interested in trying out multifocals, but they're just not quite sure, if it's appropriate for various patients. And I think everybody wants to have like a nice magic ball that tells you exactly the future. But I think just careful education, because we have to remember this generation of patients is highly motivated for spectacle independence. And you should discuss this with them and you showcase them and let them be a part of the discussion a little bit, because just telling them, oh, you have a little bit of dry eye, you're not a good multifocal candidate, or, you have, this mild haze here from old ABB, you're not a good candidate, isn't always the right answer for them. And I think that, because we now have more data, I think involving the patient, showcasing them the tools you have and saying, this is something that's going to reduce a little bit of your contrast, but with these newer lenses, we'll get there together. I have been really pleased with some of these patients who I thought, maybe 5 years ago, I wouldn't have placed a multifocal in, and they're just so happy and they're just so thrilled about their ability to read without correction at times. And so I think it's just an encouragement for everybody out there to use these devices to embrace some of these new technologies for lenses. And with that, I'm going to share a case. A 68-year-old patient who was referred for cataract surgery, complaints of blurry vision and glare. But of course, Daniel mentioned it. that fluctuation of vision. I always catch that. And, you have to really come down and say, wait, why is your vision fluctuating? This is a patient who fluctuates, from moment to moment at times. And the refraction is tough. I mean, yes, he's got a cataract. He's also got astigmatism, but he's fluctuating even on the refraction right there. And so, he's here for evaluation. We already have the surgery set up for, 2 weeks. This is his pre-op visit. And so I guess I would want to ask, John, when you look at this topography, what are you thinking already?
Yeah. You know what? This is a great one to show the patient, isn't it? So that they understand, I've got to pick a power to use, and here's your range of powers. Which one do you want me to pick? I often ask that question, and they look like, you really asking me? And I say, no, of course. But nobody knows what power your cornea behaves as. So we have to address this. So, yeah.
Absolutely, absolutely. And the issue too is these patients, they've got everything set up. I mean, nowadays, they've got their family member who's going to be taking them in. And so, a patient comes in like this, and not only am I like, where is this cornea even going with this? I'm seeing that central, the keratometry in the bottom left, and this patient wants to be, the best vision possible. And that keratometry is all over the place. And then I look at his actual, biometry here, and it's calling for 1.27 at 157. But, to Daniel's point, this sheet on the, this image on the IOLMaster 700 gives you so much data. And it bothers me sometimes when I see the residents just flip right through it, or they like lose half their sheets of paper. And this is the one that they can never find when I ask them for it. But it gives you such qualitative data on top of the topography. And for this patient here, yes, it's calling for a T4, but, this really stops you and says, this is not a toric candidate. That cornea is so incredibly irregular. And sure enough, you see him and he's got ABMD. So in my old world, I would have gone in and, started talking about cataract surgery and taking a look at him. And then just, it would have stopped my flow, because I would have been like, wait a minute, we're not talking about a toric, even though he was referred for that. We're talking about ABMD and a cornea issue. And, certainly I know many people are very smooth at changing gears completely, but it definitely adds to your time. And I love John's comment about, you only want to have one conversation. They're only going to remember so much when they walk out of your door. And so having multiple discussions and repivoting and stuff can be really tough. And so with this patient, I knew all the information going in. And then I almost knew that he had ABMD or something wrong with his cornea with that topography. I wasn't sure though. And then this certainly confirmed it. And so for me, with this patient coming in, even though he has his surgery scheduled, we have to take a step back. And so for mild disease, I definitely do what Daniel does. I'll get the topography and the biometry, maybe optimize the surface, and I'll repeat it again because it's mild disease, and they're not really bothered by it per se. And something that I'm finding, sometimes we call it like topographic ABMD, where you don't actually see any signs, but you look at the actual topography and it looks kind of schmutzy. So we're measuring it again to seeing if the biometry matches is a great option. And if it's stable, proceeding, and, maybe aim a little myopic just because you don't want to end up with a hyperopic outcome. Maybe you'll end up doing something like PTK later. But I think that can be a great option. But if it's unstable, or you're just, you see that the cornea measurements are all over the place, considering into doing some sort of cornea procedure like superficial keratectomy before is really helpful. And for moderate to severe disease, I think it's really important to address this before. And sometimes you wait 6 weeks, sometimes you wait 2 months. It's always sometimes tough to understand. I always tell the patients that I've never had a patient upset that when I saw them, I rescheduled their surgery because I found something on exam. And then I always, make it a point to call the referring doctor and say, hey, I saw them, their ABMD was a little worse than I thought it was going to be. And so I postponed their procedure. That's my gentle way of hinting, they had ABMD.
Yeah, exactly.
And so this patient had actually had a superficial keratectomy, and actually they really didn't have much astigmatism after that. And so that changed quite a bit there.
Yeah, that's often the case, isn't it? That you see less astigmatism once you've treated the disease. And Daniel, if you're going to do PTK or a procedure for Salzmann's nodule, what's your waiting time afterwards before you'll do biometry, before you'll plan for surgery?
Generally, I tell them at least a month. We know it takes about 4 to 6 weeks for those hemidesmosomes to reform on basement membrane. And ultimately, it's repeat biometry again. So come back in a month, look what the surface looks like, do a biometry, do a topo. If it looks clean, then, and again, depends on how accurate result they want. If they want just a monofocal, get something close and they're okay with glasses, then that's probably fine. If they want something that's going for spectral independence, then I'll say, hey, let's do this. We'll repeat it again in a few weeks. And at the end of the day is when you repeat, and it's stable pre-op, then you have a pretty good impression that that's the numbers and that's where it's going to be stable post-op.
Yeah. Yeah, I agree. So we have an audience question. Let's do that. And then we have, I think, just a few minutes. We can hopefully squeeze in your last case, which is an interesting one, Daniel.
Sure.
So the question is if there's is there a difference between TK and case? This goes more to your talk, Daniel. Which one is better to consider in formulas? So each of you tell us what you use and in what circumstances between. And first, Daniel, if you can explain what TK is to the audience.
Yeah, so basically TK was Zeiss's way of adding the effect of posterior cornea into a keratometry measurement. It's actually, when we talk about Ks, we call them anterior Ks, it's actually measured off the anterior cornea, but it's a estimated effect of the entire cornea. So technically a keratometry is both front and back surface. And we run into problems when those surfaces don't match the usual formula. So when we're trying to correct astigmatism, particularly post-refractive, that's a big deal. So what TK is, it basically is technically the same value, but it counts from a measurement of the posterior cornea with a measurement of the anterior cornea. So all the formulas that we use that were traditional formulas, the Virgin's formulas, the Baird regular formulas, the Hill RBF, whatever, it uses the regular K. So if you plug a TK in there, your formula is not optimized for that. You can get some funny results. Yeah. So the only formulas I would use a TK measurement in is a specific TK formula. There's the Baird TK formula that shows up on the LMS, which is nice. But I wouldn't, and also for like the post-LASIK calculations, all the other stuff, the torque calculating formulas, be careful. Don't use a TK unless you have a TK specific formula. And again, I usually use the K formulas. That's where most experience is. I'll look at the TK value. I'll look at the TK formula. And if there's a big difference, then there's some red flags. And, I usually kind of, again, look at multiple scans and see how much that variability is. But generally, I stick with the K and I look at the TK when I'm trying to correct astigmatism for patients that really care and see how much difference that may make.
Good. And your IOL master accounts for that, which formulas use the TK value.
Yeah, and it shows you that little corner as a K or TK, and it's a brilliant way that Zeiss implemented that.
That's right. Sumitra, anything to add on that question?
Well, I think I want to emphasize what Daniel said, that if you're going to use nomograms and different, formula options, you're using K, you're not using TK. Because I've seen residents try to plug TK into like the Baylor nomogram. And it's like, no, the TK is right. Using the posterior cornea, you're going to really start going down, a whole different path. It's interesting that Daniel showcased, I loved how he showcased how he runs his IOL calcs. He does multi-formulas and does the same lens. I actually do multiple lenses with just the Barrett Universal. And I print one with the Ks and one with the TKs. And that's probably because I'm using multiple lenses. I don't know which case is going to come where I have to do a Yamane. I don't know which case is going to come where I have to iris fixate. I've got different options for lenses. But I think, either way, the key is, it's okay if you have an extra sheet of paper and you're running something else. The more information, the better. But I think either way, you can run a whole list of the Ks, for example. That's what we do. And then we run the whole one for the TKs. And then we compare those two sheets. And if we have veracity, even better, less, better for the environment.
Yeah, it's done electronically. Yeah, you can see it all.
Proverbial deserted island. If I was stuck on a deserted island with one formula, it would be the Barrett Universal too.
Yeah.
Yeah, but if I had multiple lenses, that's a good one to go with. I look at the other formulas. I can't think of how it's ever changed my calculations, quite frankly. But it's good just historically to look at that.
Yeah, and there's some data that show that you get particularly good accuracy when you use the TK values with the Barrett True-K for post-refractive cases. So for me, I make sure I use those TKs for my post-refractive cases because that's shown to demonstrate. So we've got just a couple of minutes left. Let's try to do that. Let's try to do that last case to squeeze every bit of value out of this that we can. Daniel?
Sure. So here's another case, basically 71-year-old female, irregularity of the Myers here nasally, which shows the flattening of the pterygium. Probably it's indirectly affecting more here centrally where the keratometry is being measured. So basically there's a nasal pterygium, there's an unstable ocular surface. In this particular case, we did question is, do we do pterygium excision, triocular surface? We actually did a vector thermal pulse therapy, more commonly known as LipiFlow, that was done shortly thereafter. A couple weeks later, we repeated basically same day 2 measurements. We did a couple other measurements, and you look here, the exclamation points are gone. The keratometry between the 2 measurements are within 0.05 diopters. So by improving the ocular surface in this particular case, I could say, well, do pterygium surgery, give you 4 to 6 weeks, healing, whatever, and then do your cataracts. Like, hey, let's do the simple thing first. Gave artificial tears, treat the dry eyes. Came back and say, hey, the tear film over the central cornea was actually pretty good. So if you have enough of a tear film, you can overcome that pterygium. The other thing is you can tell from the topography that the pterygium itself is not specifically inducing more. You would expect more of a with the rule astigmatism if it's being induced by the pterygium, but she actually has some against the rule here. Is what we're seeing here. And that's obviously not induced by the pterygium. So we did the calculations here between the two measurements. It's within, a 1/10 of a diopter, 0.04. Put in a EDOF toric lens, and the patient has done well. So again, repeating it is kind of a quick way of seeing, hey, is there consistency? If there's a big difference, I'm not going to expect consistency post-op, so I better do something about it.
Outstanding. Sumitra, any comments?
Yeah, I think it's a great point about the fact that there can be peripheral pathology in the cornea that causes irregularities to the tear film. And this patient, has probably had this pterygium for a while. It's not growing. Why necessarily do anything about it? But if you hadn't gotten good measurements in a row, then you would have said, well, it's time to remove the pterygium. So I think that was a really great example of how it can go in totally two different directions.
Yeah, great comment. And I want to wrap things up today by thanking both of you. Sumitra, outstanding talk. Daniel, I always learn something from you. A lot of great take-home points, including use your measurements, do your measurements, do them before you see the patient, including OCTs as well as corneal topography. Look carefully at your biometry measurements so you know which ones are high quality that you can rely on. And treat what you can treat in order to normalize the ocular surface so that you get the best final result for your patient. So we have more Zeiss sessions in this series, both in anterior segment. We've got one more surgical session as well as in other areas, including retina. We welcome you to attend all of them, refer your friends. And again, I want to thank our faculty. And one more shout out actually to Truk Woodall from Zeiss, who put all this together in the background, is the really unsung hero of these educational programs. So we're grateful to her for all her hard work and coordinating everything. So thanks everyone. Have a good evening, and we'll look forward to seeing you on our next session.